Dear colleagues and friends, LUTs in patients with Parkinson's disease. These are my disclosures, and these will be the topics we are going to discuss. We start with pathophysiology of PD-related LUTs. You are well aware that PD belongs to the group of neurodegenerative diseases characterized by the progressive loss of structure and function of neurons, and the disease process in morbus Parkinson begins in the dorsal motor nucleus of the vagal nerve. From there, it takes an upward path through the lower brainstem to the basal ganglia, forebrain, until it reaches the cerebral cortex and may end up with Parkinson's dementia. So, what we should always realize that the early diagnosis is not motor symptoms. There is a spectrum of non-motor symptoms in early Parkinson's disease. That's also interesting, that's also important that the urologist knows it. In a comparative study between patients between healthy controls and early PD, it was shown that these are the most important, most frequent, the most frequent non-motor symptoms: excessive saliva, hyposmia, constipation, anxiety, and I come back to urinary urgency in a moment. So we should not think always on motor symptoms, but these are the early symptoms, and this you have to evaluate if a patient comes with LUTs, where you suspect maybe a neurological background in regards to Parkinson. This is a slide from Sakikabara. It shows that if we come to the substantia nigra, we have two types of dopamine receptors, D1 inhibitory on the micturition reflex, D2 facilitate micturition reflex, and simplified we can say LUT dysfunction, especially ORB, storage function in PD, either too little inhibition of D1 or too much facilitation of D2. And the right side of the slides shows you the coordination between the basal ganglia circuit, that's here, and the micturition circuit on the right side. And we know nowadays that there is a direct influence from D2 and D1, and there is an indirect via GABA on the micturition circuit, and this mostly is inhibitory. So we can assume that dopamine depletion will result in lower urinary tract symptoms, especially in storage symptoms. So it is no wonder that one of the most common autonomic disorders in Parkinson's disease are LUTs. They significantly influence the quality of life. We also have to realize that there is not only degeneration of dopaminergic neurons in the substantia nigra, but the disease process also involves multiple brain regions and neurotransmitters. And the fact that it's non-responsive to levodopa, that LUTs are not responsive to levodopa, suggests a very complex pathophysiology. And I think, especially in regards to LUTs, the Parkinson's therapy is not enough. We need urological add-on therapy. Well, these are, as I said, storage symptoms prevail, and especially nighttime frequency, followed by daytime frequency, urgency, and urgent incontinence. And much less frequency, we see voiding symptoms, hesitancy, poor stream, and double voiding. The question is, are these LUTs early or late in the course of disease? Well, if we see this here, then we have here 50 consecutive untreated PD patients with a mean disease duration of 2 years. And you see, if you ask them, they will say, well, there are some symptoms, mostly storage symptoms. More often you see that even in that stage, you see the detrusor overactivity in UDS, but at that stage, normal sphincter. So you have some symptoms early in the disease, but they rarely affect the quality of life. And we have shown this earlier, that if you compare the degree, the severeness of Parkinson, mild, modest, severe, and you see the occurrence of detrusor activity, then then the symptoms correlate with the severeness and therefore with the duration of the disease. So we can say urinary symptoms are present already in the early PD, but often subclinical and without affecting quality of life. Clinically important urinary symptoms correlate with the severeness and therefore duration of PD, and the time from onset of PD to initiation of LUTS in most studies averages about 5 years. Well, let's go to the diagnostic tools. Basic diagnostics, targeted history, and clinical examination. Well, it's very important in regards to the bladder to ask, when did LUTS start and when was Parkinson's disease diagnosed? If a patient comes to you and said, well, I have and says he has LUTS, symptoms of OAB, and he said, I was last month to the neurologist, and he says, I have a beginning of Parkinson, that's very unlikely that these symptoms are caused by the Parkinson. Well, we have to ask for the intake of medicaments. We have to ask if they are on-off phenomenon, which also show us that the depletion of dopamine is increasing and that the current medication is not enough, and the bladder diary. In regards to the medications, what should we know? Levodopa, well, it remains still unclear whether levodopa has any influence on LUTS. And in regards to the other first-line drug, that is dopamine agonists, there are some reports that have shown that they have storage facilitating effects. However, it's a little bit different with apomorphine. Apomorphine, there are studies who show that it increases bladder capacity, that's a good thing, but on the other side, it also decreases bladder contractility, and patients can run into chronic retention. But currently there are neither RCTs, no meta-analysis reported in the literature. Another second-line drug beside apomorphine are the MAO type 2 inhibitors. Well, they block the metabolism of dopamine and therefore increasing its level in the striatum. But if you go with the literature, there is no specific effect on the urinary tract so far described. Well, you also have to ask about bowels. Why? Well, the pathophysiology of bowel dysfunction in PD is somewhat different from that of spinal cord injury or multiple sclerosis. Firstly, you have to realize that colonic transit time is usually prolonged with PD. And it's interesting that the earliest signs of PD are found not only in the lower brainstem, but also in the gut nerve system. Secondly, that they have dystonia of the striatic muscle, which explains defecation dysfunction. And the etiology factor is also supported by the fact that in this case, L-TOPA may improve the dysfunction. So please ask in these patients also for chronic constipation. It belongs to the Parkinson's disease. And in regards to sexual function, well, common amongst patients with PD are frequent problems as decreased desire, erectile dysfunction, difficulty reaching orgasm, and sexual dissatisfaction. But there are also hypersexuality disorders, and that hypersexuality is one of the broad range of these so-called impulse control disorders reported in PD, attributed to anti-Parkinson therapy, especially seen in patients on dopamine agonists. Well, then we have also the targeted clinical examination. Don't forget to examine the anal sphincter tone and look for fecal impaction, and especially important, voluntary contraction and relaxation of the external anal sphincter. Is it possible, yes or no? It's also, we're coming back to this when we come to the indication for TOP. Well, so the typical patient coming to us, mostly advanced PD, many years of treatment, confusion, cognitive impairment, high level of disability, and bladder complaints, especially nighttime frequency or incontinence. And what is suggested management? Well, first we have to get a clear picture of what the bladder problem is. A bladder diary is very useful. And we have to say that there are often comorbidities, so we have to treat urological and gynecological comorbidities first. This may be prostate or maybe polyps. And sometimes, especially when it comes to patients which have symptoms of ORB. Together with obstructive symptoms, we do need a pressure flow EMG or pressure flow video to detect the underlying pathophysiology. We also have to realize that there could be a non-relaxing sphincter or increased sphincter activity in patients because he may try to inhibit micturition, but there may be also bradykinesia present. We will present the case afterwards, and then we discuss this in more details. I just want to stress again, there is a very old study, 1988, done by Professor Staskin, and he could show that increased urgent incontinence is not to be expected in patients after TURP if they are able to voluntarily contract the anal sphincter. However, if the patient is unable to do this, urgent incontinence may occur postoperatively. Well, then, cautious treatment. We have also said how we have to consider anti-Parkinson medication, which are dangerous, and that is only apomorphine. And for ORB, we should use those who do not cause or less extent CNS side effects. Well, the side effects are expected with antimuscarinics if they pass the blood-brain barrier, if they are bound to the M1 receptors in the brain, which are responsible for cognition. And this is just to give you an overview. These are the high-risk antimuscarinics for CNS side effects, and these are those with a lower risk, and the best is probably prospium because it does not pass the healthy blood-brain barrier, and darifenacin and solifenacin is less bound to these M1 receptors. And I just want to show you this chart here, which was just a paper published last year, and they could show in more than 451 cognitively normal older adults, when taking anticholinergics over 33, in a mean of 33 months, they could really induce a change in brain morphology and brain function. They call it increased brain atrophy and dysfunctional clinical decline. So I think for us, we can learn that if we use anticholinergics in the older, especially in patients with brain diseases, I think we should use only that we have a low risk for CNS side effects. Is mirabegron an alternative? Well, there are only 3 studies so far which could show that mirabegron is effective also in neurogenic diffuser overactivity. However, there are only small studies with few patients, no RCTs, and therefore the level of evidence is low and the rate of recommendation C. And even we know that there are beta-3 receptors also in the brain, although we do not know what their function is. So we have to be, it's also desirable to have also brain studies with mirabegron. Well, botulinum toxin is an excellent alternative because many of the Parkinson patients do not really have problems with antimuscarinics, and these are 3 studies which could really show that even a low dose of onabotulinum toxin, 100 units, can really improve their problems. Well, there are also some studies with electric neuromodulation, but an important study is, does deep brain stimulation in Parkinson's patients improve bladder dysfunction? You know that this is a method which is applied in younger Parkinson's patients who are not responsive to medications anymore. And then you implant such a deep brain stimulator, and it was shown, especially by SIFE for the first time, that the main effect of this type of stimulation in regards to the urinary tract was a normalization of urodynamic parameters in the storage phase with a delayed first desired void and increased bladder capacity. These are a chart of these studies. You see in violet stimulation off, stimulation on in blue, and if you see the maximum bladder capacity, you see you can enhance it by 1/3. So firstly it shows that this could be even a therapy for urologists, for symptoms of the overactive bladder, and it also shows the influence that Parkinson has on lower tract dysfunction. Well, a few words at the end on MSA. MSA is a progressive neurodegenerative disease with poor prognosis of life. Why do I mention it here? Because it has Parkinsonism-like symptoms. But characteristically, they have a poor response to L-DOPA, goes along with cerebral ataxia, and especially with autonomic failure. And there are quite a variety of urogenital symptoms. Urinary incontinence in MSA may be to, let's go here. This is the underlying pathophysiology. You have brainstem atrophy causing detrusor overactivity or underactivity. You have spinal cord intermediolateral columns loss with parasympathetic failure, impaired detrusor contraction, incomplete emptying. You have noradrenergic sympathetic failure, an open bladder neck, as you see it here, very characteristically. You have then, according to this, you have sphincter weakness, and you have also cerebral subtype. There is also a cerebral subtype of MSA with erectile dysfunction, urinary incontinence, retention, constipation. So if you compare these two, MSA and PD, the onset of urogenital dysfunction in the MSA very early. It often precedes the neurological deficits that they have lots. In PD, we have heard it is later in the course of the disease. Bladder dysfunction, where we have overactive symptoms, overactive bladder symptoms, but here we have very severe incontinence together with overactive symptoms. Here you usually, with PD, well, if there's no prostatic obstruction, you have not too much post-void residual urine. Here you have post-void residual urine. In urodynamics, you have DO or underactive detrusor and this open bladder neck. And in sexual dysfunction, erectile dysfunction, often the first manifestation. So we have also to think about men coming with erectile dysfunction, don't find anything. Maybe he had also starts, he will get MSA. And here in PD, it is sometimes sexual compulsive behavior. Then we come on here. So urinary incontinence in MSA patients is very complex. It can be the detrusor overactivity, to impaired bladder emptying, overflow, and due to weak intrinsic and extrinsic sphincters, mostly all of them combined. And the management is behavioral therapy, double or triple voiding, maybe cholinergics, intravesical electrostimulation, intermittent self-catheterization if possible. But the most important things, do not do any surgery in MSA patients. It always ends in a disaster. Whatever you think beforehand, don't touch such a patient surgically. I would also like to thank Dr. Saki Gabar and also Jalesh Paniker is here, that I could use some of their charts for this presentation. And my take-home message is, in PD, clinically important urinary symptoms occur late, 5 to 10 years after onset of neurological disease. Also, mild symptoms are present also initially, but they are not clinically relevant, mostly. The severity of urinary symptoms is related to neurological disability. Consider that LUTs in PD patients may be, and that is important, neurogenic, but they can also be urological or a combination of both. So we have to consider it very seriously, what we are going to do, especially when it comes to operation for TRP, for instance. For ORB, use antimuscarinics, which do not cause CNS side effects, or try mirabegron. Botulinum toxin A and also electrical neuromodulation can be the second-line treatment. And again, with Parkinson's disease and benign prostatic obstruction, TRP is possible, but as I said, increased urgency or urgent incontinence not to be expected if voluntary contraction of the sphincter ani, the pelvic floor, is possible. And here, that's my last slide now, in regards to the MSA and LUTs. In MSA, urinary incontinence occurs early or may even antedate the onset of neurological symptoms. This is, again, important for us urologists. Voiding and storage symptoms are present at the same time. We should use behavioral therapy and intermittent catheterization if possible, and we should definitely avoid surgery for LUTs in MSA patients. Thank you very much for your attention.